Liebe Kolleginnen und Kollegen, dear colleagues, I'm very happy to welcome Professor Boskurt to our today's session. Thank you very much for joining us, Professor Boskurt.
Thank you, Javed. It's a pleasure to be with you.
Professor Boskurt is the professor of medicine, is a professor of medicine at the Baylor College of Medicine in Houston, Texas. She's the immediate past president of the Heart Failure Society of America, and she has a translational and clinical research background and focuses on advanced heart failure and heart transplantation. She introduced a few weeks ago the new universal definition and classification of heart failure, which will be the topic of today's lecture. Added to the definition and classification, we will hear also an update on the treatment of heart failure. So this is super interesting. This is based on a very recent publication, and you know that the German Society in Cardiovascular Research has a very strong focus on heart failure. So I think we're all very, very much looking forward to listening to a lecture. We appreciate your time. Thank you very much for joining us today.
Thank you, Javed. I really appreciate the opportunity to present on the universal definition, and I will, in the second half, talk about the update on the treatment of heart failure to put the context of why definitions matter into the right context of treatment. These are my disclosures. The first portion of my presentation, as I stated, will focus on the universal definition and classification of heart failure, which was a consensus statement between the Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, and Japanese Heart Failure Society. It was endorsed by Canadian Heart Failure Society, Heart Failure Association of India, Cardiac Society of Australia and New Zealand, and the Chinese Heart Failure Association. So thus it was an international effort. And it was published early in March, simultaneously in Journal of Cardiac Failure and European Journal of Heart Failure. If we examine what kinds of definitions and classifications have been included in academic guidelines and scientific documents, there are usually three categories. The first one is an overarching definition of the syndrome of heart failure, which is quite important for the clinicians to define and diagnose the heart failure at bedside and or in the clinical setting. And also it's important for trial enrollment and research. Second is a classification of ejection fraction, which has been important to define categories of patients for appropriate indications of guideline-directed medical therapies, especially for heart failure with reduced EF. And the third has been stages of heart failure, which has been important for prognostication, as well as emphasis on prevention, as well as treatment of heart failure. Now we're going to start with the first one first, the definition of the syndrome. The textbook definition traditionally defined heart failure as a clinical syndrome caused by inability of the heart to supply blood to meet the metabolic demands of the body at the tissue level. Though conceptually, this is a good formulation for the pathophysiology of heart failure, the inability to meet the body's demands is not applicable to most heart failure patients. Manifestation of tissue hyperperfusion or metabolic derangements at the tissue level doesn't happen in most, but rather in a small proportion of patients. As shown on this slide, in a study of 59 stage D heart failure patients who underwent right heart catheterization before LVAD insertion, lactate levels were meant of patients with advanced heart failure awaiting VAD, and despite having low cardiac index.
Well, the connection was poor for 30 seconds. If you could introduce the slide again, that would be great.
Absolutely. In regards to the definition of inability to meet the body's metabolic demands, It's not applicable to most of the patients. The manifestation of tissue hypoperfusion or metabolic derangements at the tissue level does not happen in most. In a study of 59 stage D heart failure patients awaiting VAD insertion, lactate levels were measured as a way to define a low cardiac index. Tissue level hypoxia or inability to meet the metabolic demands of the body may be a terminal manifestation of heart failure and may not be applicable to the general patient population with heart failure. Furthermore, former guideline definitions differed significantly from the textbook definition as well as from each other. As you can see, some range from a definition of the symptoms such as dyspnea, fatigue, ankle swelling, or physical findings such as JVD or edema, but some specified hemodynamic abnormalities such as reduced cardiac output or elevated filling pressures, and some emphasize neurohormonal or circulatory abnormalities, which were not simple or easily measurable by non-specialists. It's also critical to recognize that despite the guidelines and expanding evidence for treatment in heart failure, registries with real-world patients over the last 20 years show disappointing trends with no improvement in ACE or ARB use, which remain at about 60%, or beta blocker use, which remain at 80%, and mineralocorticoid receptor antagonist use, which remain at 35% of indicated patients, suggesting lack of ability to standardize care in practice. In clinical trials, validation of heart failure diagnosis historically relied on criterion based on symptoms and signs, such as Framingham criteria seen on this slide, or episodes of heart failure, such as requiring hospitalization and overnight stay. But most of these approaches lack specificity, as symptoms can be caused by other disease entities, such as chronic kidney disease or lung disease, and hospitalization event adjudication over the years have evolved to warrant objective criteria such as natriuretic peptide levels, rather than just an overnight stay. Further complicating the issue, the care, coverage, and performance have relied on appropriate documentation and coding, which at present time is rather chaotic, representing a mixed match of academic, historical, hemodynamic, and episodes of care concepts. As can be seen, we have ICD-10 codes such as systolic combined with diastolic, congestive, acute on chronic heart failure as ICD-10 codes driving care. We have no specific codes for most etiologies except for comorbidities, and no codes for pre-heart failure except for certain cardiomyopathies. These all underline the necessity to enhance appropriate care by clarity and standardization of diagnoses that are actionable as one of the first steps to achieve uniformity of care. These ICD-10 codes are not actionable, and they are not for targeted therapies. And definitions are not only critical for understanding and communication among academicians, but also important for specialists, other care team members, regulators, researchers, administrators. We should also recognize that other disease definitions, such as hypertension, chronic kidney disease, diabetes, have evolved over the years to much more simplified definitions and have incorporated objective and quantitative markers of definition, which made the treatment targets very clear and measurable, such as eGFR in chronic kidney disease and hemoglobin A1C for diabetes. So we recognize the need to standardize the overarching definition in a simple and practical way to close the gaps in recognition, diagnosis, and documentation. We also felt the necessity to optimize and clarify the EF classification to help close the gaps and enhance treatment with guideline-directed medical therapy. And we also felt the need to further revise the stages of heart failure so it would be understandable by patients and non-specialists, and also be recognized for targeted treatment strategies, especially early on. And with these in mind, we conceptualize a universal definition of heart failure that is simple but conceptually comprehensive, with ability to subclassify and encompass stages and universal applicability, which was formulated by 33 authors with expertise in cardiomyopathy, cardiovascular disease from 14 different countries. And the new universal definition of heart failure incorporates not only symptoms or signs, but also objective markers, and is summarized as heart failure is a clinical syndrome with current or prior symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by at least one of the following: elevated natriuretic peptide levels and objective evidence of cardiogenic, pulmonary, or systemic congestion by diagnostic modalities such as imaging. In the new universal definition paper, we also expanded the symptoms and signs and included typical and less typical symptoms and specific physical exam findings, and included the cutoff points for natriuretic peptide levels supporting the diagnosis of heart failure, with a BNP level exceeding that of 35 for ambulatory and exceeding that of 100 for hospitalized, and NT-proBNP levels of 125 and 300 respectively, along with other causes other than heart failure that may result in elevations or reduction in natriuretic peptide levels. In the universal definition, we also addressed and revised the stages of heart failure. Part of the reasons for this was, though the original American College of Cardiology, American Heart Association stages definitions were adopted in societies in a uniform fashion, and though the stages A through D were recognized by specialists and academicians, the nomenclature was not widely adopted by non-specialists or were not clearly understood by patients. And stages gave the impression that there was only one direction for patients to progress from A to D, but not back. And also stages were covered under the umbrella of terminology of heart failure, even though at risk and pre-heart failure is not heart failure. Thus, it was not commonly used for people not to be stigmatized with heart failure in stages A and B. With that framework, to allow the stages to be better understood by non-specialists and also by patients, in the new consensus document, we revised the terminologies to at risk for heart failure, i.e. former stage A, and we define those as patients at risk for heart failure, but without current or prior symptoms or signs of heart failure, or without structural, biomarker, or genetic markers of heart disease. Pre-heart failure or former stage B, which we define as patients without current or prior symptoms or signs of heart failure, but with evidence of one of the following: structural heart disease, abnormal cardiac function, and the new component is the following: elevated natriuretic peptide levels or elevated cardiac troponin, especially in the setting of exposure to cardiotoxins. Heart failure or stage C, which is for patients with current or prior symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality. And advanced heart failure or former stage D for patients with severe symptoms and or signs of heart failure at rest, recurrent hospitalizations despite GDMT, and those patients who are refractory or intolerant to GDMT due to advanced heart failure status. We also emphasize that patients can improve with GDMT, and also emphasize and focus on terminologies for clinical trajectories. And we emphasize to use persistent heart failure rather than stable for those patients with symptoms, though they may not be actively deteriorating. And we also emphasize to use a terminology heart failure in remission rather than recovered heart failure for those with resolution of symptoms and or signs of heart failure, or with resolution of previous structural and functional heart disease, phase of symptomatic heart failure. supported by the results of the randomized SHRED-HF trial, which demonstrated that withdrawal of pharmacological therapy from patients deemed to have recovered from dilated cardiomyopathy resulted in a relapse in 40% of the cases, suggesting that improvement in function and resolution of symptoms represents remission rather than permanent recovery for many patients. And we envision that these simpler terms would be easier to translate to the stages to patients, especially for pre-heart failure. Similar to terminology is used for cancer. For example, pre-cancer is understandable by patients, raising the awareness and compliance for appropriate screening and prevention treatment strategies. This is critically important as we now have specific treatment strategies for patients at risk for heart failure or pre-heart failure. In the Universal Definition document, we also provided classifications for EF, defined as heart failure with reduced EF or HFrEF with EF less than or equal to 40%, heart failure with mildly reduced EF with EF between 41 and 49%, heart failure with preserved EF or HFpEF with EF greater than or equal to 50%, heart failure with improved EF, with heart failure with a baseline EF less than or equal to 40%, with more than 10-point increase from baseline EF and a second measurement of EF exceeding that of 40%. The reason it was so critical for us to standardize the EF categories was the expanding life-saving therapies for patients with heart failure with reduced EF, which now includes SGLT2 inhibitors along with beta blockade, RAS inhibitors, and mineralocorticoid receptor antagonists. And I will cover these in the next few minutes. Also, the expanding indication for ARNI, sacubitril valsartan per FDA in the United States, subsequent to the post-hoc analysis demonstrating benefit in patients with heart failure with EF less than 57%, straddling and including patients with mildly reduced EF as well as reduced EF. Also, we recently published a document on key data elements and definitions for heart failure, which we believe are going to be very useful for clinicians, researchers, administrators, regulatory agencies, individuals who spearhead performance measures, guidelines, and registries. And regarding the update in the treatment of heart failure with reduced EF, former heart failure guidelines have identified standard therapies in patients with heart failure with reduced EF to include ACE inhibitors or ARB, angiotensin receptor blockade with neprilysin inhibition or ARNI, beta blockers, mineralocorticoid receptor antagonists, hydralazine isosorbide in African Americans, and consideration of ivabradine, a heart rate slowing agent for individuals with heart rate over 70. Several landmark trials, which you all are familiar with, since these guidelines in the last 2 years provide the evidence to expand options for standard drug therapies in patients with HFrEF. And these include the sodium glucose cotransporter inhibitors, which are medications that were well known to endocrinologists, but now are accepted as cardiometabolic, cardiovascular medications. Their hypothesized cardiovascular effects appear to be beyond their glucosuric effects. They're known to reduce preload, afterload vascular tone. They result in natriuresis. They improve myocardial energetics and substrate utilization for the heart. Though we don't know the exact mechanism by which these agents confer benefit, they've been shown to be beneficial in symptomatic heart failure patients with reduced EF regardless of the diabetes. In 2 landmark trials, the DAPA-HF with dapagliflozin and EMPA-REDUCE with empagliflozin, which included patients with HFrEF with EF less than or equal to 40%, symptomatic heart failure with elevated natriuretic peptide levels, and half of the patient population was without diabetes. And both studies showed that treatment was very effective in reducing cardiovascular mortality and heart failure hospitalizations in patients with reduced EF. And the magnitude of benefit was very similar regardless of diabetes status in both trials among patients with or without diabetes. Furthermore, these new therapies, including SGLT2 therapies and ARNI, have beneficial effects beyond heart failure or cardiovascular disease, SGLT2 inhibitors reduce the decline in EGFR, prevent progression of renal disease. And please note, as seen on the right upper panel, there is an initial decline in EGFR with a transient rise in creatinine due to reduction in glomerular hypertension, which then stabilizes and is better when compared to placebo with SGLT2 inhibitors. And in the CREDENCE trial conducted among patients with diabetes and CKD and albuminuria, SGLT2 inhibitors delayed the need for dialysis by 15 years. ARNI also reduces the decline in EGFR as seen in the left lower panel of the slide. Thus, these new therapies have beneficial effects with evidence of slowing the progression of kidney disease. The magnitude of risk reduction with SGLT2 inhibitors in patients with HFrEF is quite robust, in the order of about 25% risk reduction in combined cardiovascular death and heart failure hospitalization, 30% risk reduction in heart failure events, and about 50% risk reduction in decline in CKD events. And meta-analyses also support that these agents are associated with a reduction in all-cause mortality as well as cardiovascular death. And from the patient's perspective, there's also evolving evidence that these life-saving therapies, SGLT2 inhibitors and ARNI, are also associated with meaningful improvements in quality of life measures, as shown in the upper panel with dapagliflozin and empagliflozin. They were associated with meaningful improvements in quality of life measures in the DAPA HF and EMPEROR trials, and sacubitril valsartan with improvement in quality of life in the PARADIGM trial. And these studies also reported improvements in LV volumes and EF, suggesting reversal of remodeling in patients with HFrEF with ARNI and SGLT2 inhibitors. There's also evidence of cardiometabolic beneficial effects of these agents. In DAPA-HF trial, dapagliflozin prevented new onset of diabetes in patients with HFrEF without diabetes, without causing hypoglycemia. And in PARADIGM trial, ARNI was associated with improving glycemic control among patients with HFrEF with diabetes. The safety and tolerability of ARNI and SGLT2 inhibitors are very favorable, with ARNI demonstrating lesser risk of worsening renal function or hyperkalemia, but more symptomatic hypotension compared to ACE inhibitors, and SGLT2 inhibitors showing no excess or hypoglycemia, ketoacidosis, symptomatic hypotension, worsening renal function, or hyperkalemia, regardless of diabetes, age, renal function, but increased risk of genital infection when compared to placebo. As I mentioned, in the EMPEROR-reduced trial, hypoglycemic events were not increased even in patients without diabetes with empagliflozin, and empagliflozin was not associated with any increases in volume depletion. And it's important to recognize that these benefits were apparent on top of very optimized background therapies, reflecting over 90% of the trial population being treated with RAS inhibitors and beta blockers, and over 70% being treated with MRA. And there was no heterogeneity according to background therapy. Benefits with SGLT2 inhibitors were consistent across all subgroups of background medications examined, with no difference among patients with or without background treatment with ARNI. And recent analysis of the EMPEROR-reduced trial demonstrated that use of MRA did not influence the beneficial effects of empagliflozin. There was significant benefit amongst those treated or not treated with MRA. And interestingly, treatment with empagliflozin was associated with less discontinuation of MRA, suggesting facilitation of optimization with other agents. Furthermore, in a recent study with sotagliflozin, which is an SGLT2 and 1 inhibitor, showed a significant reduction in cardiovascular death and heart failure hospitalization and urgent heart failure visits in patients with diabetes hospitalized with heart failure regardless of ejection fraction, with no differences in benefit among subgroups of patients with reduced or preserved EF, and or among patients who were initiated on sotagliflozin before or after discharge, suggesting that these agents can be initiated before discharge. So if we examine the armamentarium of life-saving therapies in patients with HFrEF, recent trials support addition of SGLT2 inhibitors to the standard therapy of patients with HFrEF, along with beta blockade, RAS inhibitors with ACE inhibitors or ARB or ARNI, and mineralocorticoid receptor antagonists, solidifying the basis for a quadruple standard core therapy. And we have additional evidence with two specific therapies, the first one being vericiguat, an oral guanylate cyclase stimulator resulting in cyclic GMP production, with favorable effects in myocardial remodeling, vascular stiffness, and prevention of fibrosis in experimental and earlier studies, which was studied in the Victoria trial in patients with HFrEF. And also a second agent, omecamtiv, a novel selective cardiac myosin activator, which stabilizes myosin in the pre-power stroke state and increases the duration of systole without increasing myocyte calcium and oxygen consumption. This oral agent was shown to result in improvement in contractile performance in phase 3 in patients with HFrEF, but was associated with increased cardiac troponin and ischemic events in the earlier studies, and was recently studied in the GALACTIC trial. Though the agents differed significantly, the trial enrollment population was very similar, so I will represent both of these trials in the same slides. Both studies enrolled sicker patients with heart failure with reduced EF, with history of heart failure, hospitalization, and elevated natriuretic peptide levels. In Victoria, with vericiguat, shown on the left side, patients with systolic blood pressure less than 100 or eGFR less than 15 were excluded. In GALACTIC-HF, with omecamtiv, the inpatients as well as outpatients could be enrolled, and only patients with systolic blood pressure less than 85 or eGFR less than 20 were excluded. Both agents resulted in modest but significant reductions in the combined endpoint of cardiovascular death and heart failure hospitalization rates, most attributable to reduction in heart failure events, but failed to show any improvement in cardiovascular death. Both studies had significant heterogeneity by subgroup analyses. In Victoria, patients with the highest quartile of NT-proBNP levels did not appear to benefit from vericiguat, raising the possibility that sick but not too sick patients may benefit from vericiguat. In GALACTIC-HF, there appeared to be benefit in patients with heart failure with EF less than 28%, but not more than 28%. And regarding their effects on patient-reported outcomes, we currently don't have the results of quality of life from Victoria trial with vericiguat. In GALACTIC, omecamtiv treatment was associated with trends for improvement in quality of life, which didn't reach the significance of a pre-specified p-value by a close margin. Regarding their effects on remodeling, vericiguat did not result in reverse remodeling. Omecamtiv has been shown to result in improvement in LVEF and chamber volumes and stroke volume in the earlier phase 2 COSMIC trial, and we are awaiting results from the GALACTIC trial to see whether there was evidence of reversal of remodeling with omecamtiv, despite lack of benefit in cardiovascular mortality. Both agents overall appear to be safe and well tolerated without excess of serious adverse events or without any adverse effects on electrolytes or kidney function compared to placebo. In Victoria trial, vericiguat resulted in a trend for higher risk of symptomatic hypotension and syncope. In GALACTIC-HF, there was no evidence of hypotension, in fact, no effect on blood pressure, but there was a minimal increase in troponin in the magnitude of a difference of 0.004, but without accompanying increase of clinical myocardial ischemia or ventricular arrhythmias. So at this point, beyond the standard core therapies of beta blockade, RAS inhibition with ACE inhibitors or ARNI, MRA, or SGLT2 inhibitors, or hydrolysis and isosorbide in African Americans, management of patients with HFrEF can also be individualized according to special populations and disease phenotypes. There could be consideration of ivabradine for patients with elevated heart rate despite optimal doses of beta blockade, or perhaps vericiguat for patients with recent worsening of heart failure, but those who are not hypotensive or with markedly elevated NT-proBNP levels. If approved by the FDA, consideration for omecamtiv for patients with current or history of repeated hospitalization with lower EF or perhaps even lower blood pressure. It's also important to recognize that there is evolving evidence, not only or solely for morbidity and mortality, but also for reversal of remodeling, quality of life, functional capacity, patient-reported outcomes with all these expanding therapies, providing valuable information for patients as well as clinicians. As can be seen, not all medications that improve survival improve quality of life, or vice versa, and therapies will need to be specially prescribed according to patient preferences, as well as clinician guidance. It's also important to recognize that beyond initiation of standard therapies for heart failure, it's critical that clinicians should make every effort to diagnose and treat specific etiology. We emphasize that in the universal definition as well. As seen on the right side of the slide, there are a variety of diagnoses that require specific treatment strategies. For example, amyloidosis or tachycardia-induced cardiomyopathy or chemotherapy-induced cardiotoxicity will require specific strategies beyond routine treatment of HFrEF or HFpEF. Treating a patient with amyloidosis without recognition of the diagnosis as HFpEF can result in adverse outcomes. Treating a patient with amyloidosis with HFrEF, with reduced EF, with routine GDMT could result in adverse outcomes. Thus, specific treatment strategies are critical. There's also evolving evidence that we need to consider specific treatment strategies for comorbidities, such as treatment of anemia, or iron deficiency anemia, or diabetes, or hypertension. In hypertension, systolic blood pressure target to a less than of 130 is critical. Treatment of iron deficiency with IV iron and management of valvular heart disease, such as mitral regurgitation, after optimization of GDMT is critical. Evidence with these new life-saving therapies after early treatment underlines the importance for a quicker combination uptitration strategies rather than the traditional approach of a stepwise uptitration according to the historical sequence of a trial. So we need to achieve optimization in an individualized manner quickly without delayed treatment. In summary, evidence supports that the foundational core medical therapy in patients with heart failure with reduced EF should include RAS inhibitors with ACE inhibition or ARNI, beta blockade, MRA, and SGLT2 inhibitors, not necessarily initiated in a sequential or delayed manner, while focusing also on specific etiology that may warrant specific treatment in addition to the routine GDMT or beyond routine GDMT, individualization of additional therapy according to race, comorbidities, disease phenotypes, trajectories, and risk, with shared decision according to patient goals. While not delaying the initiation and optimization due to inertia or perceived stability or presumed intolerability of patients. And regarding heart failure with preserved EF, guidelines reflect emphasis on treatment of underlying etiology and comorbidity in patients with HFpEF, such as treatment of blood pressure or AFib or ischemia or focusing on decongestion. And in addition to the pre-existing class 2B recommendation of ARBs to reduce heart failure hospitalization in 2017 due to the trial results of TOPCAT, a new recommendation was added for MRA use as a class 2B recommendation that MRA might be considered to decrease hospitalization in select patients with heart failure hospitalizations or elevated natriuretic peptide levels. Subsequently, we had the results of the Paragon trial, which showed that though sacubitril valsartan did not significantly reduce total hospitalization and cardiovascular death in patients with HFpEF, it resulted in improvements in quality of life. The p-value came close to significance for heart failure hospitalizations, but did not reach the significance and remain in that borderline stage of 0.056, and there was no effect in cardiovascular death. There was significant heterogeneity with specific interactions in subgroups of sex and LVEF, suggesting possible benefit with sacubitril valsartan in patients with lower ejection fraction below 57 and in women. And as I showed before, post-hoc analysis revealed benefits in the spectrum of ejection fraction up to normal EF. And this spline analysis actually reflects very similar results with also ARBs and MRAs in patients with HFpEF. These resulted in expansion of the FDA indication for sacubitril valsartan in patients with heart failure without specification for EF, as seen on the first sentence, to reduce the risk of cardiovascular death and heart failure hospitalization in patients with heart failure. That's the FDA package insert indication. But it's followed by the following sentence: benefits are most clearly evident in patients with EF less than normal. Studies with SGLT2 inhibitors are ongoing, and the results will be released, we're expecting, at the ESC. And of course, there are ongoing studies with intraatrial shunt devices, spironolactone, as well as non-steroidal MRA, such as finerenone, in patients with HFpEF, which will provide further information about treatment strategies in patients with heart failure with preserved EF. Finally, I want to really emphasize the changing paradigm for patients at risk and pre-heart failure. And I am using now the terminologies we use in the universal definition of heart failure. So regarding the burden of heart failure, if we examine the spectrum of heart failure from at risk to advanced heart failure, from stages A to D, majority of heart failure patients are at risk or pre-heart failure stages. Even in the US alone, with 100 million with obesity, 115 million with hypertension, and approximately 100 million with prediabetes, 1/3 of the US population is at risk for heart failure or stage A. For patients with diabetes, who are by default considered to be at risk for heart failure, many trials show that SGLT2 inhibitors result in reduction in cardiovascular death or heart failure hospitalizations with SGLT2 inhibitors. Most of these studies were conducted in patients with diabetes with cardiovascular disease risk or with cardiovascular disease, and resulted in 30 to 35% risk reduction in heart failure events. Less than 10% of the patients enrolled in these trials had established heart failure. Thus, they're considered to be prevention studies for heart failure. These results raise the question whether we can determine which patients with diabetes are at a higher risk for heart failure than atherosclerotic endpoints. The reason for that is there is evidence that other agents beyond SGLT2 inhibitors, such as GLP-1 receptor antagonists, can result in improvement in outcomes in MACE endpoints or atherosclerotic cardiovascular endpoints. So a patient with diabetes, we know, is at risk for heart failure, at risk for ischemic heart disease, atherosclerotic cardiovascular endpoints, and kidney endpoints. So all patients with diabetes have risk for all of these endpoints. And there are different agents resulting in different benefits in outcomes. How will we know which patients are at a higher risk for heart failure when patient has diabetes? One trial that provides us a perspective on this is STOP-HF trial, which was a study conducted in a randomized fashion, looking at the role of screening with natriuretic peptides in an annual basis, conducted in about 1,300 patients with cardiovascular risk, such as patients with diabetes, hypertension, or coronary artery disease, but without heart failure or without LV dysfunction. They were randomized to annual natriuretic peptide screening versus usual care if the BNP level exceeded that of 50, which is a rather low value. Patients were referred to a multidisciplinary management, including cardiology and imaging. BNP-based approach had higher number of cardiovascular investigations, higher utilization of RAS therapy, and significantly reduced future development of heart failure and LV dysfunction, both systolic and diastolic, and MACE events, majority of which were driven by reduction in heart failure events. These findings resulted in addition of a new recommendation in the 2017 heart failure guidelines, stating that for patients at risk for developing heart failure, such as patients with diabetes, natriuretic peptide-based screening followed by team-based care, including a cardiovascular specialist optimizing GDMT, can be useful to prevent development of left ventricular dysfunction or new onset of heart failure. This raises the possibility that we can define a higher risk of patients for heart failure by biomarkers, as we did in the universal definition, such as natriuretic peptides or cardiac troponin, and try to prompt consideration for specific treatment strategies for all stages, including pre-heart failure. New screening strategy, we believe, utilization of the universal definition of heart failure will move the paradigm to earlier. That's what is going to be the biggest impact of the universal definition. So we believe standardization of heart failure syndrome definition with a simple but conceptually comprehensive definition with acceptable sensitivity and specificity, including symptoms, signs caused by cardiac abnormality and corroborated by elevated natriuretic peptide levels or objective evidence of congestion by diagnostic modalities, are first steps to enhance appropriate diagnosis and optimization of GDMT and achieve uniformity for standardization of care universally. New revised terminologies for classification, such as at risk for heart failure, pre-heart failure, with inclusion of biomarkers, heart failure and advanced heart failure likely will be easier to be understood by clinicians, not just by specialists and also by patients. And it will help us utilize specific treatment strategies for pre-heart failure as well as heart failure and advanced heart failure. EF classifications, we hope, will provide clarity and standardization for heart failure with reduced EF, heart failure with mildly reduced EF, and heart failure with preserved EF, as well as heart failure with improved but not recovered EF. An emphasis on trajectories for terminologies for persistent heart failure rather than stable, to prevent inertia or presumed stability, like in cancer. So we don't want to stop. We do not want to stop therapies in a patient presumed to be stable. That patient has persistent heart failure and therapy should be optimized. And also we emphasize utilization of heart failure in remission rather than recovered heart failure for patients and or the clinicians not to have a false presumption that the patient is cured, and so that they do not stop the therapy and continue. And finally, it's critical that on top of the foundational therapy with guideline-directed therapy, we really emphasize diagnostic strategies to be carried out to define specific etiology. We define this in the universal definition, and we want to disseminate this as a critical necessity to make sure that diagnoses that warrant specific treatment will also be implemented. And the therapy can be individualized according to phenotypes. In sicker patients, other additional therapies may be considered. Treatment of comorbidities, especially in diabetes, hypertension, iron deficiency anemia, sleep apnea, requires specific approaches. Risk trajectories, comorbidities will help further refine targeted therapies. Do not forget the importance of lifestyle modification and incorporation of patients' goals, whether they're focused on quality of life, morbidity, mortality, as well as overall well-being. Thank you for your attention.
Thank you very much, Professor Bosco. This was an amazing talk. I learned a lot. Dear colleagues, a few questions came in. So if you have questions, put it in the chat, either on YouTube or in the WhatsApp group we have, and I'm happy to answer questions. I would start with a definition slide you had. You introduced, so the new universal definition of heart failure includes symptoms and or signs caused by a structural and or functional cardiac abnormality. My question is, how do you know that the symptoms you see are caused by the abnormality you see?
That's a great question. We wanted to increase the specificity. For example, volume overload in an end-stage renal disease patient coming in with pulmonary edema, right? There's congestion, the BNP could be up. Knowing that, and of course, these patients may have an overlap of HFpEF as well as HFrEF, as well as it may be just due to missing that dialysis. Now, in the definition, and I didn't verbally state, we do have the statements as the following. Caused by a structural and or functional abnormality as determined by low EF, abnormal cardiac chamber enlargement, structural abnormalities and functional abnormalities in diastology, such as E over E prime, valvular abnormalities that are in the significant moderate to severe range, and or structural abnormalities that are in the maladaptive hypertrophy phase. So I think those, which we have known historically and were actually embedded in a lot of the guideline definitions. For example, ESC had that definition attributable to heart. If the heart looks totally normal and it looks like there is volume overload, and that the volume overload is not due to the heart, but to the kidney or to the liver failure, calling that heart failure may not do a service to the patient.
So 2 or 3 weeks ago, we were happy to have Professor Barry Borlaug with us, who talked about HFpEF. And he said that, especially in the case of HFpEF, the natriuretic peptides have very low sensitivity.
Absolutely.
And we learned that E2E prime is mainly a surrogate for filling pressures and LVEDP, and as a correlate for stiffness. And the reasons you mentioned and which are listed on the slide, filling pressure, increased filling pressures were not listed, and I'm sure there is a reason why you didn't.
They are listed in the second component, which is the first one is natriuretic peptides, and the second one component, it says objective evidence of congestion by diagnostic modalities, including imaging and or hemodynamics. And we also even have a sentence over there, and I can share again my slides if need be, at rest or with provocation. That's for HFpEF, because as you know, the filling pressures, even in right heart cath, may demonstrate normal filling pressures, normal NT-proBNP, and even the E over E prime may change with dynamic maneuvers, either volume and or provocation of exercise. So we recognize that. And if you will, let me see whether I can go back to sharing that slide so we can accentuate that message. Give me 1 second. I'm trying to go out of the presentation mode. Okay. And I'm glad you asked that question because it's critical for us to make sure that everybody, so as you can see, and you will see this in the text, so that's why I invite everybody to read it. Objective evidence of congestion and or hemodynamic measurement, right heart catheterization, PA catheter at rest or with provocation, i.e. exercise. So that's for HFpEF.
Okay, yes, very good. So I would go to the next question. So of course we see a lot of patients with tachycardia-induced reduced pump function, and when we solve the problem with a heart rhythm, the LVEF improves. How do you showed that DCM patients which improved with heart failure treatment, and when under the withdrawal of treatment they get worse again. Do you think the same about tachycardia-induced heart failure, or how do you deal with them?
Induced cardiomyopathy is one of those rare entities, especially if caught early and is not accompanied by another second hit with comorbidities, would be reversible or curable in the real sense, as we see in the pediatric and young adult population. Those usually recover. Now, very interestingly, though, the cardiomyopathies in the DCM right now have further downstream characterization by phenomapping and or signaling. So these individuals who develop myopathy, right? Some individuals do not, and some do with tachycardia. So the predisposition is metabolic derangement and or a signaling derangement. And would they be able to tolerate a second hit in the lifetime, viral disease and or another, let's say, cytokine surge or something of that sort? It's interesting to see that. And I think it's in gradients, meaning who truly recover. And if you look at the TREAD-HF, 40% relapse, not the rest. So who is truly reversible? We say 50% of peripartum cardiomyopathies are reversible, but we also say patients who develop peripartum cardiomyopathy may have genetic predisposition, the truncating variants, like we are saying, that are in the common denomination with the DCM. So if they have a genetic predisposition, would they be prone to a second hit, developing cardiomyopathy in the future? So we're unmasking these things very gradually. So peripartum cardiomyopathy, alcohol-related cardiomyopathy, if early, right? So I sometimes say a college, or a young individual who had a binge drinking, and this was, carried out in experimental studies in animals as well as in, young individuals. There is a reversibility, but the ones that we see nowadays with lifelong consumption of alcohol, with the fibrosis, with the scarring, does not reverse. So who reverses? Toxin-induced cardiomyopathies, Herceptin, we say, is reversible, but adriamycin is not. So tachycardia-induced cardiomyopathy, if caught early, is usually reversible, but depending on why the tachycardia was from, right? So if supraventricular, usually you treat that, it's reversible, but ventricular tachyarrhythmias and the bigeminies, why did it start with? Chicken egg story. If it's the myopathy that created the arrhythmia and the tachyarrhythmia, PVC ablation in DCM, as you know, is a double-edged sword. If the etiology may be beneficial, but then the amount of myocardium you lose with each ablation may further decline the EF. So I think what I'm trying to say is clinical gestalt, as well as looking for underlying pathophysiology that made them vulnerable to develop that at the first place, are important. Therefore, genetic profiling is also as critical in DCM patients, regardless of the proximity to another cause, is as important. And I think this is evolving. And I think with further phenomapping approaches or strategies, we may have opportunities to see where people are in recoverability, right? We are just starting to scratch the surface of that. Maybe downstream Wnt and or other fibrosis markers, because I'm aware of like the CM phenomapping concept of looking at cardiometabolic versus fibrosis concepts as different. When you come to the low EF and your cardiac metabolism is gone, reversibility is very low. So these are early fibrosis may reverse, but late fibrosis would not. So I think those are going to be important. even in those entities that we perceive to be fully recoverable. But we want to emphasize the 40% that is going to relapse, because we want continuation of therapies rather than immediate cessation.
Could you highlight why you introduced, so in this context, why you introduced heart failure with improved EF?
Yes, it's very, I'm glad you asked that question. It's mainly for devices, right? So improved EF, even if the EF has improved, we're going to continue the therapy and not stop. But at the same time, are you going to do a defibrillator? If it's one of those tachycardia-related genotypic abnormalities, maybe they will have another indication if they had sudden cardiac death history and so forth. But otherwise, individuals whose EF has improved to that improved EF, more than 40%, they probably are not going to require a defibrillator or CRT. So the distinction for improved EF is for not warranting a device therapy after optimization with medical therapy.
Thank you. So the goal of, so you showed that registry data does not reflect the improvement we could achieve during the very nice trials and great trials we had over the last 20 years. And one of the reasons you concluded, as far as I understood, is that we have to improve, one of the vehicles we have to improve this is to have a better and more standardized definition of heart failure. When I, as far as I understand heart failure, and we see only treatment success in heart failure with reduced ejection fraction. And we don't see it in HFpEF. With the treatments we have, and we see this effect, with a bit differences in HFrEF, regardless of the cause of the reasons why the patients have developed heart failure in the first place. So somehow the effect of the treatment is regardless of the reasons. Why did you in the new definition again focus on the EF? I think it would only make sense. We can say, my idea is HFrEF. If the EF is below 40, this is the medication you should use. So this is, and this is not because it makes sense to rely on the EF, but it's the way the trials were done. So this is the only population we know that they work on. Probably they will work in other patients too, but we don't have the tools to identify. We haven't developed the tools to identify these patients. This is, why am I saying this? The reasoning for the HFpEF trials, which didn't work, was that the population was too heterogeneous. Was not the same type of. They don't have the same type of dysfunction, and so we cannot have the same effect in these patients. Does that make sense, or where am I wrong?
Three answers for you. The sequence will change according to etiology, even if you were to use a standard therapy. For example, tachycardia-induced cardiomyopathy, the way you're going to approach that is, you're not going to wait, I'm going to optimize this until you go and ablate that SVT. So the sequence matters. What you do matters. Amyloidosis, which could be HFrEF and HFpEF, you could harm the patient if you were to just use the garden variety guideline-directed therapy. And what we are seeing is, as we're trying to standardize the whole workforce, do not remain static. The second answer I have is, we want to emphasize optimization in all fronts. Like guideline-directed therapies need to be enhanced because there is satiety and inertia. What does that mean? Majority of the reasons in the CHAMP registry for not optimization was not patient-related. It was perceived stability. The blood pressures were definitely with a availability to optimize further. So patients were on 2 agents at most, low doses, with the perceived stability, not intolerance, not due to side effects, not due to low blood pressure. Lack of optimization in the CHAMP registry, if you look at all the studies, were perceived stability. So we want to definitely change that paradigm. perceived stability is like saying stable cancer. And if you're not optimizing therapy, it's like not giving chemotherapy to your cancer patient because the cancer is progressing rather stably. That is one arm of the intervention in the universal definition. But at the same time, we're also aware of amyloidosis patients being misdiagnosed, right? And the prevalence of amyloidosis is rather high. We know that patients with even aortic stenosis, when they're going to TAVR, now being recognized with. So this concept of can you do harm if you do not specifically diagnose? Yes. Is it a small population? I don't know the answer. And amongst HFpEF, that could be a large population. So we need to also be specific. And I'm going to again give the cancer terminology. Yes, they do have pathway-driven chemotherapeutic agents, but then they do individualize, right? So we just can't treat all same of HFpEF or HFrEF. Do look at first sequence, optimization according to what the risk is. Cardiac toxicity, right? We do have evidence with certain agents with chemotherapeutic agents and lack of benefit. So how I start which agent at what level in the peripartum, what we are able to use during the pregnancy versus not. So these diagnoses are not the majority of the population attributable causes of heart failure. The population attributable ones are hypertension, CAD, diabetes. And that's why those, and obesity as being the last, that's why those four were the standard risks that were identified in stage A traditionally. Why didn't we put, cocaine or, alcohol or at those times, viral myocarditis as a cause was due to population attributable risk not being high. So the burden was not high, the relative risk was not as high. So, but at an individual level, if you see that etiology being there, then it needs to be addressed.
Why do you draw a line between HFmrEF and HFpEF?
Primary reduced EF is a entity that is dynamically changing. It's not staying in one area. So you need to know the trajectory. It's either HFrEF becoming PEF or PEF going down, and the direction matters. It's critical and it's heterogeneous. You could have restrictive cardiomyopathy, you could have ischemic heart disease. So it's a mixed batch. It's not a neurohormonally activated HFrEF patient, if you will, neither a HFpEF patient, and it is in between.
So I have two more questions, if that's okay.
I have to jump on another call, but I'll do it quick.
Sure. So patient-reported outcome measures were introduced and were stressed by you. These are mainly secondary and tertiary outcome measures in the trials we have. If it's that important, do you think that we should improve the level of evidence for patient-reported outcome measures and have PROM focused as a primary outcome measure?
Yes, because they're important for the patients, right? And they're important for goal-directed discussions with the patients. And the patients will need to tell us whether they'd rather walk more or breathe better, and at different stages in their life. And I think that matters. Yes, the answer is yes, we need to have better outcomes planned at the design phase for these secondary outcomes. And they're also being considered at the regulatory level as complementary portfolio for approval of medications.
Perfect. Last question by Dr. Bloom, a colleague of ours. He said that at the moment, the treatment recommendations are based on an incremental basis. So we start and then we add. Do you, with the data you showed, that we have a lot of new target drugs? What do you think about it?
I want to emphasize not sequentially according to the historical publication of the trials. I think that is not going to be the right strategy. I would emphasize personally optimization according to the phenotype of the patient, the etiology of the patient, whether I would start post-MI, I would, a patient with ischemic heart disease, chest pain, right? Beta blockade along with the other RAS inhibition, high blood pressure. I would be adding on a variety of other agents. SGLT2 inhibitors can start rather early, depending on the HFrEF and phenotype of the patient. So I would individualize, not delay, optimize as much as you can. And even the patients can optimize quite a few of these agents, like MRAs, 1 or 2 doses, SGLT2, 1 dose. So no necessity to wait.
Professor Boscott, It was amazing, and it was an amazing lecture. Thank you very, very much.
You're
And I'm very
welcome.
much looking forward to our next meeting.
Thank you. It was a pleasure, and I really enjoyed the opportunity. Thank you again.
Thank you very much.